Welcome everyone, and thank you for joining us to the side session at escaide 2022. We will be talking about modeling the future of living alongside COVID-19 in Europe, and we will discuss and show you here today some of the insight that modeling can provide us with. My name is Sandmann. I am part of the mathematical modeling team here at ECDC, and I will be the moderator of this session. You can also see a picture of our modeling team on the right of this slide, and if you see any one of us during the next 3 days in person at the conference, please feel free to say hello. escaide 2022 is also organized as a hybrid event, and for those of you joining us online, you can of course also just email us. Just to note that this event was pre-recorded on 08 November, and so at the time of the streaming, please don't be surprised if we do not address the latest news of the day. Our speakers are also available in the conference chat if you want to ask them a question, and we will try to avoid going too much into technical details as we aim to make this presentation as insightful as possible for a broader audience. With that, I am delighted to introduce our three speakers. We will start with Professor Sebastian, who is a professor of infectious disease dynamics at the London School of Hygiene and Tropical Medicine. Most of his current work is using real-time modeling and forecasting during outbreaks to aid decision-making. He's also the academic lead on ECDC's European COVID-19 forecast and scenario hubs. And Sebastian will present us with insights about modeling the future of COVID-19 in Europe. Our second speaker is Dr. Rebecca Borchering, who is an infectious disease researcher working at the US Centers for Disease Control and Prevention in the National Center for Immunization and Respiratory Diseases. She co-led the development of the US COVID-19 scenario modeling hub and now focuses on influenza modeling, including both scenario and forecast hub efforts. Rebecca will talk to us about the impact of the COVID-19 pandemic on other infectious diseases, with a special focus on the seasonal influenza virus. Our third speaker is Professor Philippe Beutels, who is a professor of health economics at the University of Antwerp in Belgium. For over 25 years, his research has focused on mathematical models, economics, infectious diseases, and public health. He is co-director of the Inter-University CIMID Consortium in Belgium and the director of the Center for Health Economics Research and Modeling Infectious Diseases. Philippe will give us an overview about the longer-term health and economic consequences of COVID-19, including on post-acute COVID. In order to set the scene for our three talks, let us jump right in, and I will present this one slide on the burden of infectious diseases in Europe. This figure shows you the pre-pandemic situation with, on the horizontal x-axis at the bottom, an increasing number of annual cases per 100,000 people, and on the vertical y-axis on the left-hand side, an increasing number of annual deaths, again per 100,000 people. Please note that both of these scales are on a log scale. And just to note that this figure was published in Eurosurveillance in 2018, so 2 years before the COVID-19 pandemic started. It is also showing a static picture of the burden, but the main purpose really here is to give an indication about how COVID-19 is going to fit into this. If we now look at the recorded COVID-19 data so far in the European surveillance system in 2022, we can see that the rates for COVID-19 are in fact the highest of all infectious diseases, both in terms of the incidence and mortality recorded since January 2022. This brings us to the first question of how will the COVID-19 epidemiology change in future? The next question is going to be, what will be the impact of COVID-19 and the non-pharmaceutical interventions on other infectious diseases? And you can see there is a long arrow pointing to influenza. And lastly, the size of the bubbles in this figure actually represents the disease burden expressed in disability-adjusted life years, or DALYs, which combine the health loss for morbidity and mortality into a single value of life years. The larger these bubbles are, the worse the disease burden is. ECDC and others are currently working on quantifying this burden for COVID-19 as well as the wider economic impact, and we will have Philippe tell us more about this too. With that, I would now like to ask our first speaker to present us with modeling the future of COVID-19 in Europe. So please, the floor is yours.
Thank you very much, Frank, and thank you very much for giving me the opportunity to speak here. I'll be mostly speaking about a couple of projects that we've done in collaboration with and also funded by ECDC, the European Centers for Disease Control, as well as in collaboration with a number of modeling teams across the world to model the future of COVID-19 in Europe. And when we talk about modeling the future or using models as a tool to explore an unknown future, there's actually quite a few different things that we can mean by this. So we're talking here about computational or mathematical models that describe the trajectory of case data or hospitalization data or deaths. And in this case, in fact, I'll show you these three pictures are three examples from modeling done for the UK government. All these describe hospitalizations, but the context is quite different. So in the first one here, what I'm showing here, these are forecasts. And when we talk about a forecast, what we're trying to do is we quantify the probability of different future outcomes. So you can think of this a bit like a weather forecast or something. So you have a 20% chance of rain tomorrow or something. What we're trying to do here is very similar. We're trying to describe what is the probability of hospitalizations going up or down or having a certain value. So these, in that sense, are what we can consider true predictions that can be confronted with reality later. Secondly, and distinct from forecasts, we have projections. And projections are statements of what would happen in the future under an assumptions of no change. So we have a model that we can calibrate to the past data, and then we project it forward in the sense that we assume nothing is going to change. So it gives us an idea of if the current trend were to continue, where we would end up. And what you can see if you compare these two pictures here is, so this is from April 2020. This is only 2 weeks ahead. And generally speaking, for something like the COVID pandemic, forecasts are only possible a few weeks ahead. Again, you can, without wanting to labor the analogy too much, you can think of this a little bit like a weather forecast, which only really works a few days in advance. And beyond that, there are simply too many factors in the system that the models can't describe, and we lose confidence in the forecast. But if we make a projection, we are no longer making a true prediction because we have this explicit assumption that things were to stay the same as they are now. In reality, they often might not. Behavior might change, or there might be a change in interventions or something. But if things were to stay the same, you can then sort of reasonably, under this proviso, extend this at a longer horizon in the future. So here, for example, this is 6 weeks ahead. This is from later in 2020 in October, looking again at hospitalizations with the peak of the first wave in March, April here. And then in October, if things had continued as they were, then the expected trajectory is shown as this. And then there's some alternative trajectories here. And in fact, in early November, a partial lockdown was instituted, and this scenario didn't come to pass, or this projection didn't come to pass, because things didn't stay as they were. And then taking this even further, we can make scenarios. So we can create specific explicit assumptions on about the future, such as what if we had this or that intervention, or what if we were following this or that vaccination policy. Or in this case, so this is from 2021, around the time of the emergence of the Delta variant in the UK, where it wasn't really clear what the level of immune escape was from Delta. What if Delta had 10%, 20%, and so on and so forth, level of lower or higher immunity compared to wild type. So when we're making scenarios, we usually choose these to be plausible, but we don't make any explicit statements about how likely each of them is. So in that sense, we've lost the connection here to them being predictions. Okay, coming on to what we actually did and how we did this in Europe. So the first project was that we started a European COVID-19 forecast hub in March 2021. So the idea was for this to be a place to gather forecasts from forecasting teams using a range of different models and methods to make short-term predictions up to 4 weeks ahead of cases, hospitalizations, and deaths in 32 European countries. And so I mentioned these are, I've talked about probabilities before. So these are probabilistic predictions, meaning they don't just tell, or the idea was not just to capture what the most likely future trajectory was, but also to capture the uncertainty around this. So you can see here, this is from one particular point in time, the data up to this point, and then a forecast. You can see this expanding cone because the further you go into the future, the more uncertainty you have. Up to now, we've had 58 different models from 44 modeling teams, collected more than 10 million forecasts, and every week the inputs from the different models are combined into an ensemble forecast for each of the countries, which is a bit like forming a consensus between these different models and modeling approaches into a kind of consensus prediction. And so talking about kind of insights and trying to think about the insights that we've gained from this sort of exercise. So here you can see an example of the forecast made at different times, and the kind of insights that we've gained from this is that an average of models, so this ensemble, so-called ensemble, which is an average of all the models that have been produced in any given week, generally makes better predictions than any individual model. So there's some value in this kind of wisdom of the crowd from the different models. At the same time, the forecasts really, especially of cases, so the kind of the immediate epidemiological indicator, really have turned out to be reliable only for 1 or 2 weeks ahead. And we haven't, none of the modeling teams has really been able to improve on this, just highlighting the inherent uncertainty in COVID, in the pandemic so far, at least, with changes in behavior, changes in policy, perhaps, and also uncertainty around immunity and new variants. The subsequent indicators of hospitalizations and deaths, because they are trailing indicators, are a bit easier to forecast and can be reliably forecast a bit further into the future. The other thing is that the identification of turning points due to new variants or due to changes in behavior or due to immunity has proven incredibly challenging. And you can see this a bit here. Generally speaking, the forecasts follow the trend. And when there's a change in trend, we continue to make a prediction, and you can see it clearer here. In January 2020, this for Germany, cases in Germany, it's difficult for models to capture the turning point. This one here at the top, the turning point to a decline was captured perhaps a bit better. So this is the forecast hub, and these are short-term forecasts, and they're somewhat limited because they are only valid for such a short time frame, so they make it difficult. You can't really use them for planning purposes. And so in order to have a longer term vision, we also created a scenario hub. So remember, scenarios are no longer predictions, but are explicit. Assumptions are explicit, and then under given explicit assumptions, they are views into the future. So the European COVID-19 Scenario Hub started in January 2020, collates scenario modeling results for, again, a range of indicators. We have fewer models here. Generally speaking, for scenarios, you need more complicated models that encompass a lot of epidemiological information than for forecasts. So there's a smaller set of models here. And then also, we don't do this week by week, but it's more infrequent rounds with sets of scenarios for the models to consider, and the scenarios are chosen to be plausible and policy relevant. And again, we don't make any statements about how likely each of these scenarios are. And just to give you a few examples, so we've looked at things like new variants, waning immunity, different types of vaccination, booster campaigns, and as well as more recently, annual vaccination programs. And you get these sorts of trajectories. So you have here in different colors of different models, and you can see you can get quite a variety of outcomes from the different models, as well as in the different countries. And we can use these to try and gain insights into plausible and possible futures of COVID-19 in Europe. And so to summarize, so I've already mentioned the insights from the forecast hub. We can make good forecasts in the very short time. Identifying turning points in advance is difficult. Delayed indicators are easier to predict, and the ensemble makes the best forecast. And with the scenario up, we've seen that long-term scenarios can look quite different in different models as they make different assumptions, and it's therefore important to always consider multiple models. Where they do agree, then, for example, we've seen this in our work on the importance of waning immunity. This really improves confidence in the results. And for more detail on this and the scenarios and their interpretation, I'd invite you to look at the talk by Catherine Sherratt in the Fireside Session 1. Thank you.
Thank you very much, Seb. That was brilliant. We are now going straight to the next talk from Rebecca on modeling the impact of COVID-19 on other infectious diseases, in particular influenza. Rebecca, please, over to you.
Thank you so much, Frank, and to the organizers for inviting me. I'm really excited to have this opportunity to share some of the things that are going on in the US now with respect to disease dynamics in the face of COVID, and I'll go ahead and get started. So we have this recent report about changes in influenza and other respiratory virus activity during the COVID-19 pandemic. And I guess as one might expect, non-pharmaceutical interventions that target the virus that causes COVID-19 also impact other respiratory virus transmission. So if you're wearing a mask, it's going to prevent influenza virus from passing through your mask, as well as hopefully SARS-CoV-2. So we did see decreases in historic lows in influenza virus circulation and other respiratory pathogens after non-pharmaceutical interventions were put in place for COVID-19. So in this plot, you can see the percentage of positive specimens and the black and dashed lines for influenza A and influenza B have so fairly seasonal activity through 2020, but then when the COVID-19 pandemic came in, these positive specimens, the percentage that were positive dropped to essentially zero. And this wasn't entirely for a lack of testing. You can see the blue shaded region is the number of specimens tested. So there was still testing for influenza and other respiratory viruses, but they just weren't circulating. So a few things changed. So there wasn't a huge forecasting effort when we didn't have circulation of influenza in the US, but influenza activity did pick up in 2022, and we did have a 2021-2022 influenza season flu site forecasting challenge, and a few things were new for this challenge. So recently, flu site forecasting used influenza-like illness as a target, but that's characterized by cough and sore throat. So those symptoms are overlap with COVID symptoms, and it's really hard to interpret that data now that we have multiple pathogens circulating with similar symptoms and also changes in care-seeking behavior as a result of the pandemic. So the forecasting target shifted to confirmed influenza hospital admissions, and this was also in part due to a new unified data set in the US that reports daily confirmed COVID-19 and as of February 2nd, 2022, influenza outcomes. So these forecasts were up to 4 weeks. They were available at the national and state level and produced weekly starting in January 10th. And then we were able to extend the forecasting effort beyond its original end date of May 13th to June 18th because of atypical late season activity. So fortunately, a lot of the takeaways that Seb shared also hold for flu forecasting in the US. It's really hard to predict more than a week or two ahead. So when you get to that 4-week horizon, it's pretty difficult to capture what's going on. And also, so here I'm showing ensemble results for the forecast, and those are generally more reliable than the individual model forecasts. So we did manage to have 15 to 20 teams per week. This was a particularly difficult time. Teams were also adjusting to forecasting COVID, so it was a pretty valiant effort. And we're keeping the new target of hospital admissions for the 2022-2023 season, which is currently underway. And we started October 17th. So please do feel free to check out that link for the latest forecasts on the CDC website. So I also want to address that we're now having an atypically early season of influenza in the United States. So this is a plot of percent of outpatient visits with influenza-like illness, and I recognize it's problematic because there are multiple pathogens that look like influenza sometimes, but we're also seeing matched increases in hospitalizations, not quite matched, but parallel. So you can see this really sharp and atypically early increase in influenza activity. And to address these longer term scenarios, as Seb mentioned, that maybe relate to changes in behavior or immunity or intervention decisions, we also have used a scenario modeling hub approach. So this started with COVID-19 in December 2020, and now after 15 rounds has expanded to include flu scenarios. And the axes of uncertainty that were considered in this first round include different levels of immune protection pre and post pandemic, so 50% reduction in immunity based on not being exposed to influenza in the past few years. and then also different levels of vaccination coverage and vaccine efficacy. And we can see for these first few dots, these tiny dots of observed data, they're tracking fairly well with the reduced prior immunity scenarios. So you can see there's still a wide range, and we'll see what's to come. But these scenario projections are a really helpful way to think about what could happen under different sets of assumptions. So I'll close with thanking my CDC colleagues, as well as all of the modeling teams that contributed to the forecasting and scenario hub efforts. Really, this wouldn't be possible without you, as well as the public health officials, clinicians, staff, everyone working in the hospitals and laboratories that put together this data. It's another critical element to these efforts. So with that, I will close. My contact information is at the bottom of the slide, and I would be happy for you to reach out. Thanks.
Thank you very much, Rebecca. I think this is a great example, right, for how like some of the modeling tools can actually, that we use for COVID, can also be applied for other diseases like influenza. We will now move on to hear from Philippe about the longer-term health and economic consequences of COVID-19, including on post-acute COVID. Philippe, over to you.
Thank you very much also for giving me the opportunity to talk in this session. I'll talk briefly about the main concepts related to health economics and in the context of the pandemic, of course. I think it's important to distinguish two phases. There's a first phase of emergence and mitigation where there's little to no immunity built up yet. So you have an overwhelming aspect of the healthcare system, both from the disease itself, as well as there are influences from risk perceptions and the measures that are taken that can lead to postponement of care. And there's also a lot of focus on maintaining the healthcare capacity for all kinds of care. There is an obvious impact also on mental health, both from the disease in this case, also for COVID, as well as from all these measures and the risk perceptions. And on top of that, because of these risk perceptions and the changed behavior of consumers and investors, there's a perturbation of the general economic equilibrium, which means that classic health economic methods are no longer adequate to address this. And that's why we've seen very little in the early stage of the pandemic, very little of classic health economic methods being applied to this problem. So in terms of cost effectiveness analysis. And this is now, when we get into the stage of control where immunity has built up and we're reaching a new equilibrium, both in terms of the burden of disease, where this new pathogen has increased the burden of disease in our populations, as well as where the economy is coming to a new equilibrium. We're reaching also a stage where we're understanding this new pathogen in terms of the consequences it presents acutely as well in post-acute stages. And we can start to try to analyze using classic health economic methods what the burden of disease is that this pathogen represents in terms of quality of life years or disability adjusted life years, as mentioned earlier, and also the impact of interventions on that disease burden. For the post-acute stages, most people will know there is a problem with definitions. So there's a lot of different definitions being used in terms of terminology, as well as the timing at which these consequences are observed. So that means also that the risk estimates, the risk of developing post-acute COVID, long COVID, chronic COVID, etc., has got a wide range over it, also depending on which method has been used. And that creates a lot of uncertainty about the actual disease burden that we can expect in the long run from COVID in our populations. It also creates uncertainty for the estimation of the value we attach to these health states. And the typical way of doing this in health economics is to do health-related quality of life studies. And so these risks, as well as these values, are determined very much by which subgroups you're looking at. So obviously, there's a difference in risk as well as in the severity of illness when these are patients admitted to ICU, to hospital in general, or not hospitalized at all. When you're looking at them, which time point, how long after infection or the onset of symptoms, whether or not, if you're looking at the general population impact on quality of life, so more an overall assessment of the measures and the risk perceptions. It also depends whether you're doing this during confinement period, during a peak period of disease burden. And has been noted in many studies now is the difference between variants and whether or not we're dealing with breakthrough infection or not. So these things, these values and these risks are changing as the pandemic is unfolding. And this is creating a lot of uncertainty about how we project towards the future this burden. As already been mentioned, there are several initiatives on estimating the burden of disease. I just flag a recent one I'm aware of is the European Burden of Disease Network, with the link provided in the slide, where they're estimating DALYs for European countries directly related to COVID-19 in the population during the first two pandemic years. We also know that mental well-being is affected by both COVID-19 and the NPIs, but what does that mean in terms of mental health, and how does that mean? How does that translate into a QALY or a DALY impact in the short term as well as in the long term? And just to illustrate this very briefly, these are data from a study that we did in Belgium over 46 waves of mental well-being assessment in over 3 million people that responded over these waves, where you can see that on the bottom you have the hospitalizations, the admissions in Belgium, so two big waves in 2020. But on top of the top chart, you see the sensitivity of mental well-being in response to the evolution of the curve. So this is both the disease burden that's driving this, but also, of course, the measures that go with trying to control it, especially in the emergence and mitigation phase of the pandemic. Later on, the sensitivity of mental well-being response as measured by the GHQ-12 score at the top. This is a standardized score, so the higher the score, the worse mental well-being. This sensitivity is going down a little bit under the influence of vaccination, where there has been a decoupling of hospital admissions and ICU admissions in the later stages of the pandemic. And what we observe is that mental well-being impact is especially the highest in the younger age groups, and especially amongst the youngest age group, 16 to 25 years, those that are students. That's the top curve. So the higher the score, the worse your mental well-being. Well, the older age groups have been less affected. But the key question now towards the future is, of course, how does this immediate response in terms of mental well-being translate into mental health, harder clinical aspects like depression, and so forth, and how does that translate into a QALY assessment or a DALY assessment? On the side of the economic aspects that I mentioned in the beginning, I just want to show here the evolution of a number of key economic indicators from the beginning of the pandemic until April 2022, where you can see that this typical V-shaped curve occurs mostly related to economic sentiment, which lingers on for a longer time than, for instance, retail. So we've seen a lot of adaptation in the economy immediately after the pandemic, after the pathogen hit, where e-retail has been very important in mitigating some of these economic consequences. But what we also see is that around the second wave of the pandemic in most of Europe, you see the dark gray scale is getting darker towards the fall of 2020, whereas the economic impact has been much less pronounced. So in some way, the economy has adapted to dealing with this problem. And in future pandemics, we should be able to reduce this V-shape much more than we've been able to do in this pandemic. So by being better prepared. and appropriately evaluating preparedness for pandemics, we can try to prevent this deep shock in the economy. In the meantime, many EU indicators are at pre-pandemic levels. That's shown in green in this table from Eurostat also, where GDP, of course, is the most key or general one, but all these other aspects are also returning to normal levels, or at least pre-pandemic levels, or at least cannot be attributed to pandemic causes. In the meantime, of course, other important things have happened. So in summary, I think there's a new higher background disease burden that we experience around the world, also in Europe due to COVID-19, which is still very uncertain. There may be knock-on effects on the severity of other diseases. So we know it affects the heart, the lungs, the brains, but also there's fatigue, which is much harder to pin down. So there's a lot of research needed to document that. A key question for me is, what is the optimal interpandemic capacity of healthcare systems? And how flexible should we make this to deal with new pandemics? What's the increasing role of EU cooperation and the mental health impacts? As I mentioned, how do we account for that through a utility assessment, so through QALYs and DALYs? The general economic equilibrium is likely relatively stable now, despite continuing NPIs in Asia. So this can still have effects, perhaps also new variants of concern. But in the meantime, the war and climate change may start to dominate these equilibrium much more than COVID-19. So there is much more of a role for classic QALY-DALY optimization research, where we look at cost-utility analysis. In terms of future preparedness, I think we should try to value much better how we can approach building up flexible vaccine production capacity. For instance, also deal with healthcare surge capacity. How do we value that well in advance of a pandemic so that it's in place? Stockpiling also of essential goods. This has been a problem in many countries. And also structural changes, which is look at the value of structural changes in dealing with pathogens in the pandemic, and also in interpandemic periods. And finally, I acknowledge the EpiPost project, of which I'm part in this final slide. Thank you.
Perfect. Thank you, Philippe, for this really comprehensive overview. And thank you, all three of you, really, for this quick rundown through all of these three topics. I think it was very interesting. We will now take the time for me to ask a few questions to all our speakers to reflect on the differences of modeling COVID-19, the impact on other diseases like influenza, and the health economic implications of the COVID-19 pandemic. This is also just a reminder that if you are watching the streaming of this event at escaide 2022, that you are very welcome to ask your questions in the conference chat, and our speakers will try their best to answer you. My first question is to all of you. In your view, what are the priorities of modeling in the changing landscape of COVID-19 for the next months and years ahead? Shall we maybe start with Seb, then Rebecca, and then Philippe?
Yeah, so I think it might be useful to distinguish here between the short and the long term, a bit like I did earlier in the talk, with sort of forecasting versus long-term scenarios. I think in the short term and in monitoring the modeling for monitoring the epidemic and situational awareness, the key thing that changes is new variants emerging. And I think modeling to rapidly understand transmission advantage of any new variant and immune escape is going to remain relevant, especially if at any point we are to have a variant which is sort of has the potential to cause significant new morbidity and or mortality. In the longer term, I think, besides that, and obviously the difficulty, I don't think we're in a position where we can model the long-term evolution and emergence of new variants, so we'll have to sort of take that as an unknown factor in modeling the future. But I think in the longer term, the impact of waning immunity from immunity that has been acquired by different means, whether it's via natural infection or via the vaccine, waning of particularly immunity against severe outcomes, and understanding that better, I think will be a key factor for modeling the future landscape of COVID-19.
Yeah, and I think from the multi-pathogen side, it definitely making the distinction between the short-term and long-term is really important. I think there are a lot of key modeling questions that are very timely right now with influenza coming back and RSV, but it's a little unclear what will actually be possible on the short time frames since they're already coming back. So really thinking about what are the important questions and what can modeling help address on the short time scale that will still be relevant is, I think, important. And then on the longer time scale, I think it will be really important to think more about modeling interactions between different pathogens, whether that be through non-pharmaceutical interventions that affect multiple pathogens. They could be immunological interactions. So thinking through how we can effectively model the different pathogens interacting together in a very complex immune landscape will be important over the longer term.
I agree with all of that, and I think that modeling the burden of disease from non-severe COVID in a better way and the impact on other diseases is really very important. Trying also to model the effectiveness and the cost effectiveness of using vaccines and other interventions in a more routine manner. I think will be very important. And this is also, of course, closely related to understanding the waning boosting mechanisms better and to implement that in models.
Thank you for that. This is a great segue maybe for another question on how can these different types of modeling that we have seen today complement each other, especially if we think about forecasting and scenario modeling and of health outcomes like cases and deaths versus health economic outcomes like DALYs or productivity costs. Shall we make another round of all three of you?
Shall I start again?
Yeah, sure.
Yeah, so I'm not sure I have a good answer to this question because we have so far, I think, treated them as quite distinct questions. The questions of forecasting and scenario modeling, and then health economic modeling, kind of again as a separate issue. I think we've seen the importance of all three of them, but how they can complement each other. I mean, maybe I can say something about forecasts and scenario models where. I think forecasts of COVID-19 have maybe taught us some humility in kind of how we really need to be careful with interpreting the output of models, because even if models kind of under the specification of very specific scenarios can seem quite precise into the future, the actual level of uncertainty has been vast, and so which affects any kind of modeling of the future of COVID-19. And that said, I think the ability to forecast can maybe be a useful indicator for the reliability of the scenario models, and kind of can also tell us when we maybe enter a phase, which could happen, where COVID-19 dynamics becomes more predictable, because we don't have drastic behavioral changes anymore, perhaps as we've had, or political intervention. Dynamics are largely driven by variance and immunity, and so I think from assessing the predictability of any models, I think we can potentially learn something about then at the same time kind of how much we need to caution the predictions from scenario models.
Yeah, and just to lead, I think, directly off that, I think communicating uncertainty is so important, and we've learned a lot about that as we've moved more into the scenario projection phase. And so just continuing to communicate what can we reliably say from these forecast or scenario projections, for how long, I think another thing that's come up is really having a strong handle on the data that's going into calibrating the models. What is it that is being forecasted or projected into the future? Is it cases, hospitalizations, and deaths? Knowing how that reporting is changing through time can be very challenging when things are changing very quickly. So just being cognizant of that and really working closely with the people that are collecting the data and managing the data has become, I mean, it's been apparent, but I think been strengthened through the COVID-19 experience.
Yeah, I think that health economic modeling by nature is mostly based on scenarios. So in that respect, but you also need to have a pretty stable current situation. So that's your projection. That's part as one of the scenarios. I would consider that, and then you have all these multiple outcomes that we try to consider simultaneously. You have all these intermediary outcomes like cases, hospitalizations, deaths. That is a final outcome, but on top of that, in a health economic sense, we try to estimate the quality-adjusted life years or the disability-adjusted life years associated with that. And so all of that is part of these types of integrated models. And I think that's where they really complement. We really have to rely on transmission dynamic models for this for quite a while, I think. And that's why they need to be integrated for the health economic purpose as well.
Thank you. I think that makes a lot of sense what you're saying. If we maybe move to one other question on, so reflecting essentially over the last years, right? Another question for all three of you, maybe, essentially aiming at what do you think we can actually learn from modeling COVID-19 for other infectious diseases, and how has our understanding of modeling other infectious diseases been informing the modeling of COVID-19? Shall we do another round of Seb, Rebecca, and then Philippe?
Yeah, so I think, so I'll start with your second question, which is that I think, decades of experience in modeling other infectious diseases have kind of laid the foundation for being able to do this work that ourselves and modeling groups around the world have been doing. So I think to some degree, many teams, I think, were able to draw on, just at least to some degree, on existing models for other respiratory infections that by changing some parameters could be applied to COVID-19. In terms of what could be learned for other diseases, I think some of this perhaps we knew before, but I think it's really come to the fore that we cannot ignore the aspect of human behavior, and we can't really predict behavior and behavioral responses to interventions. I think there's a lot more work that will have to be done on this. And also we can't ignore heterogeneity in susceptibility and heterogeneity in exposure. And again, I think there's some kind of reflection and learning to do there. And then the other thing I think we've learned a lot about is that immunity is not a yes or no state. I mean, again, this is something we knew, but it's really something that's come to the fore with modeling and understanding COVID-19 is that, and I think that's something that may also affect our understanding and our modeling of other infections.
And yeah, those were all great points. I think building specifically from my experience, the importance of hubs where multiple modeling teams get together during these times of really great uncertainty for huge public health concerns has been a positive development in modeling, and also we're starting to see it in flu. I think it will hopefully continue into the future as more critical questions continue to arise, and the frequent interactions that the modeling teams have as part of those hubs really improves modeling overall. And we see in the ensemble the improved performance, I think, helps with when you're trying to make a decision, having that one answer that at least takes into account some of the differences between the models without overwhelming the person looking at the results. And then also, I think incorporating different data streams through COVID, using virological data, other sources of data that will be important for modeling other pathogens in the future. And then just again to double back on that, being in close contact with those that are collecting the data and reporting the data, and also sharing results and having that back and forth communication, because it really is a huge effort on hospital staff and other people contributing to the data. So to share that the modeling really is using those data streams is, I think, important to make sure we can continue these efforts.
Yeah, I also agree that we learned a lot from behavior by doing many social contact studies. So before the pandemic, it was usual for a country to have maybe had 1 or 2 social contact studies done that in the last 10 years, let's say. But now during the pandemic, there are many countries in Europe where they had more than 30, 40, 50 such social contact studies, and we can closely relate that to the observed force of infection. Not only from COVID, I think we can also look at other pathogens and learn from that massive data gathering that has been going on during the pandemic. Also across disciplines, the type of work that we usually do is multidisciplinary by nature. If you combine health impacts with economic impacts and so on. But during the pandemic, that really has increased a lot and put, like has been said before, all these different teams together, comparing their models, being open about the models much more than was usually the case before. So I think that's really helping the whole field forward very much in a very fundamental way. And I hope that can continue in the future.
Thank you very much to all 3 of you, really, for participating in this session and for sharing these insights. I think given the time, we need to conclude now here. I hope you in the audience found this event useful and it made you think more about what modeling can actually do. I hope that I want to thank the ECDC colleagues who have helped us organize this event and make it run smoothly. I want to thank the modeling team at ECDC, who I am representing here today. And above all, of course, again, a big thanks to our 3 speakers for having joined us from 3 different time zones, I should mention. And I hope that the applause in the room you cannot hear, but it's hopefully transporting. Thank you very much for listening in. I hope you continue enjoying the fantastic program of escaide 2022, and bye for now.